Welcome to this special episode of Around the Room, recorded on-site at the CRA's 2026 annual scientific meeting in Halifax, Nova Scotia. Hosts Dr. Daniel Ennis and Dr. Janet Pope welcome special guests to bring you a daily roundup of highlights from the ASM. This special episode has been made possible in part by Boehringer Ingelheim. Thank you, Boehringer Ingelheim, for your generous support in sponsoring this episode. The scientific integrity and objectivity of all podcast content is overseen by an independent CRA committee to ensure the highest standards.
Welcome to this final special edition of Around the Room from the Canadian Rheumatology Association annual scientific meeting here in beautiful Halifax, Nova Scotia. Very happy to be joined in person by my co-host, Dr. Janet Pope. How you doing?
I'm doing great, and we're on the countdown to the gala.
That's right. Yeah, that's right. That's where I shine. And to help us with our last daily roundup, we're lucky to be joined again by the University of Calgary's Dr. Marinka Twilt, who is the ASM Program Committee Chair, and the University of Alberta's Dr. Osman, who is the Abstract Chair and Co-Chair of the ASM Planning Committee. Nice to have you both with us.
Nice to be here again.
Thanks for having us.
Of course. So let's jump into day 3, busy day, lots of interesting content to talk about. So maybe we'll start out, first things first was the podium presentations. Mo, did anything stand out to you or anything that you wanted to highlight from the podium presentations?
Yeah, so honestly, I thought all the podium presentations were phenomenal. However, 2 podium presentations really stood out for me. The first one was by Dr. Katie Healy, who's an internal medicine resident, but she presented some really interesting data related to sex differences, related to non-sex chromosome-related changes in psoriatic arthritis. And it really shows us that a lot of these things that we are seeing clinically can really be explained by genetic changes or maybe epigenetic changes. So I think it's a big step in the right direction related to this, and hopefully this will help us really understand these differences clinically, but also develop biomarkers that can help us really personalize kind of approaches to treating females and men. The other podium presentation that was also really interesting was actually presented by one of the Peds Rheumatology Fellows, Dr. Asmari, who's part of Dr. Linda Hiraki's group. And he presented a new novel mutation in a monogenic mutation called SAT1 variant of unknown significance that was essentially associated
Our favorite variants are those
Yes,
unknown significance.
Yes,
Yeah.
and they were characterizing it nicely and showed that this was really highly associated with pediatric lupus and neurocognitive kind of challenges in this patient. And this is only the tip of the iceberg. They're obviously going to have to do a lot more work to figure out how this actually relates to lupus ultimately. But I think it just reminds us how complex some of our diseases can really be.
Excellent. Marinka, anything that you enjoyed from the...
Yeah, another one that really caught my eye was from Amanda LaPlante, who's actually a second-year medical student at McGill, who talked about Health Canada indications and formulary coverage of biologics and synthetic disease-modifying anti-rheumatic drugs for JIA. And it just shows how poor it is, and also how poor it is in certain provinces compared to other provinces. So you can better be as a patient in Ontario than you can actually be in one of the other provinces, because Ontario has more coverage than any of the other provinces, which is not very equal in care. So the inequity in JIA is high anyway, and then it's even higher because of the fact that not all provinces are covered the same. So that was very interesting. Of course, there's also no Health Canada indication for these medications, so you cannot really blame them, but it does show the inequity in care that we can provide in pediatric rheumatology because we just don't have any of the access to any of the medications.
And the sad thing is the RCTs are there, but often by the time they're done in the kids, patent extension hasn't existed, so they don't take it to Health Canada and go through the rigorous approval process. So you're acting on proven data, but then you can't get access because it's not approved for it.
Yeah.
It's tough.
Yeah. And sometimes even the 16-year-old to 18-year-olds are in the trial. So then you could say, could you at least use that to help, at least for the older age group, but they still don't allow that.
Jana, what stood out to you?
First of all, the talks again, I thought as well, were fantastic. Dr. Justin Smith did his Jeff Carr Lupus Fellowship with Zai and the rest of the group, so Zai Tuma. And he looked at cognitive impairment and SLE. And I'll tell you right now, there's a lot of brain fog and we never know what to do with it. So they estimated in their group of over 600 patients where they did a bunch of tests on them that about a third had brain fog. And they wanted to compare basically a questionnaire that would be very subjective to very objective testing. And the problem with objective testing is it takes many hours. It's these ACR tests, and it's just not feasible to do it. And the bottom line, as I suspected, but was a bit discouraging when I have to go tell patients things, was that there really was almost no correlation between the objective and the subject. So that's the first thing, which is unfortunate. And the second thing is we really don't know what to do about it. Big problem, the brain fog. And we often can say, might not be your active lupus, it could be pain, sleep disturbance, the meds, hydroxychloroquine goes into your brain, prednisone does, etc. So I thought, though, at least it was very helpful to say the correlations are weak at best. Some things are more correlated in different items, but if you put the whole test together, the easy one, which is a self-reported questionnaire, it really doesn't correlate. Anyway, he did an excellent job discussing it, and I think I have a better understanding in that area.
So that then takes us to the state-of-the-art lecture. Marinka, what were your big takeaways from that excellent talk?
First of all, that Mike Umbrello is still my hero. He's a good friend, but he's very passionate about Still's disease and adult onset Still's disease. I think for what we in pediatric rheumatology really noted is this anxiety of ILD, the development of ILD. And I think he gave some really practical tips of like how if he has a new patient, does he start anti-IL-1 and anti-IL-6? Does he not start? What kind of screening does he do? So I think it really helped to have those clinical tips. And if you went to his workshop afterwards, he even gave a couple of like case presentations of like how to do that. And it was very interactive with lots of questions. And I think it helped people with feeling a little bit more secure maybe in what to do, although I think people still don't know what to do. But I think it was an amazing lecture. Yeah.
So then I think we all had a chance to see some of the posters, but there's too many for us to go through in detail. So maybe
high quality, high caliber,
Excellent.
Lots of attendance there for sure.
But maybe we can then talk about the workshops. Marinka already mentioned the Stills workshop. You attended that one, did you, Mo?
Yeah, so I went to the Stills workshop, and I have to say I'm an adult rheumatologist, and whenever we get a question of is this adult onset Stills disease, we're not really sure because we have to look for lots of things before we do. And I have to say, Dr. Umbrello provided this nice 10 kind of summary statements about Still's disease during the lecture. And then the workshop, he really went into it a little bit more about the ILD aspect. And something I learned from this are, number one, adult and pediatric Stills are the same, right? It's just slightly different rules or criteria that people follow, and the presentations might be slightly different. But I think more importantly, I learned about the relevance of the HLA-DRB15 biomarker, which is very helpful in predicting kind of complications, particularly the ILD and the associated drug reactions, which I actually didn't really know about. So sometimes we always think maybe our medications are helpful, but in this particular case, sometimes our medications can be detrimental, which I thought was something very eye-opening for me.
Mo, you mentioned the 10 things that he mentioned in the Stills talk. Do you want to share that with listeners?
Yeah, of course. So the top 10 include Still's disease is the same condition in children and adults. Number 2, early treatment of Still's disease leads to better long-term outcomes, which makes sense as a rheumatologist. Still's disease is unique and drug repurposing is unsuccessful, which tells us how little we actually really understand about Still's. And generally speaking, most of us use anakinra or IL-1 therapies like canakinumab or IL-6 directed therapies. And this was one of the things that he highlighted was very effective. But one of the things that we really need to remember is about life-threatening lung disease and drug-associated immune reactions. And he went on about what that actually meant during the workshop related to IL-1 and IL-6 inhibitors is something we have to pay close attention to in our patients. And as I mentioned, HLA-DRB115 alleles are the strongest predictors of the Still's-related lung disease and these drug-associated immune reactions. And discontinuing IL-1 or IL-6 directed therapies may improve clinical outcomes in Still's, as I was referring to earlier, which is a little bit of a paradox almost, but not very intuitive, but it is interesting. And something that he really touched on the workshop were the JAK inhibitors, specifically ruxolitinib, and its potential kind of promise in Still's disease that is very refractory to therapy, but obviously more studies are required, and careful screening and recognition of the lung disease is critical. And he did go through multiple algorithms during the workshop that were intuitive or based on some data, which is interesting as well. And finally, Still's disease is a really multidisciplinary disease requiring lots of teamwork, so rheumatology, pulmonary, hematology, and so on.
And I would have just one extra thing to say that I think I'm surprised about, because we usually get referred the fever of unknown origin if they present as an inpatient, they have a rash, and we're trying to see if their temperatures are even done.
Yeah.
Not to mention if they're like monocyclic or daily cyclical. But what he said was 42% of these systemic onset JIA or probably adult onset stills are monophasic. So we think we're like really smart. They get some prednisone, they go home, they're all better, we never see them again. But the other half, 51%, are persistent. And then there are definitely some kids in that small percent that they're pretty good for years, and then they re-present as an adult. And sometimes, depending on where they're from, they didn't know that they had stills. And if you take a better history and go, why does your wrist not working right, or your neck or something doesn't move right? And you find out that they actually probably had stills as a kid, and then it wakes up, say, when they're in their 20s, etc. So I found that was really helpful. The other thing is I totally under-recognize, at least in the adults, the association of Still's disease with ILD. Like I would have thought, wow, he's talking a lot about, and I don't know a lot about it, and I don't even know if I've seen it. So I wonder if I've missed it, both the diagnosis of the Still's, adult onset, and or the complication. Because when they come in with fluffy lungs, we think they're PJP and other things. And I think if it persists, we have to really think about what to do and to stop the treatments that to me would be obvious to work that don't work. And try probably a JAK or something.
100%. And I think during the workshop, he went through how he would approach working up a patient who has suspected lung involvement. And for me, that was extremely helpful, because I have to say I never have access to someone who's a real expert in an area that like Mike is. And I was asking, and Marinka was there too, she can comment, I was asking very granular questions, which I thought was very helpful for me.
And I think also there are some cohorts out there that have much better outcomes. So he mentioned that as well. There's the Dutch cohort that actually after 3 months, a lot of them can stop the anakinra and they're like better. But it's still a heterogeneous disease. And if you don't have arthritis, is it really a JIA, systemic JIA Still's patient, or is it like an autoinflammatory disease that might have reacted
or neither?
Yeah, or neither, or a hyperinflammatory reaction to something. So I think there's still so much like not known in this area, but it's nice that at least this ILD, which really surprised all of us, at least now gets a little bit more teased out, and people now feel comfortable with, okay, I should not increase the anakinra or the canakinumab, but I should actually stop it and switch to another class like the JAK inhibitor, which is, I think, really helpful for our patients that we can do that, because it seems to be reversible if you stop on time, which is also very nice.
Very interesting. Okay, so then that takes us to Rheum Jeopardy, which was, I think...
hard.
That
It's
it's not
hard.
lupus. It's not lupus. So tell me about the Parkinson thing. Daniel, you were there.
Yeah, so one of the photos shown was of hands that looked very Jacquard's arthropathy to me. And I think this one, I think it was the West Coast that was asked this question. And we got it wrong because the majority of people said that this was lupus, and Jacquard's related to lupus. And the answer ended up being Parkinsonism, which was a real surprise. I'll have to go home and read about kind of MSK manifestations of movement disorders and Parkinsonism, but that was really...
Now, if it was a live little video, you could have seen the tremor and then you'd know it right off. But
Yeah, that's
I
probably
didn't
why
know
they took the
looked like
photographs.
Jacquard. Yes.
And at least I can say, as a pediatric rheumatologist, I do not see Parkinson's. So at least I can say I'm
Do with some kind of syndrome mimicking.
But that was really great and really well hosted, as always. Then finally, we had the Distinguished Investigator keynote by Cheryl Barnaby. Janet, what were your kind of thoughts?
So first of all, kudos to Cheryl Barnaby. She has had really a career dedicated in many areas to providing health services to the Native peoples, the First Nations people. She has had a connection there that is difficult to make. You have to really meet you have to meet people where they're at, but in the location where they're at as well, not just where their brain space is. And I think what it really made me reflect on is that the inequities are great in access and in outcomes. She mentioned that prejudice is often an experience when the patient comes into the clinic. Somewhere along the way, the person in the elevator looking at them or commenting on their clothes, or the parking attendant, or who knows whom. And I think that is just so sad, because it's a big deal when you're traveling a large distance to come. People are afraid to go to a rheumatology appointment as a regular person going for the first time. If you've had to travel all this way and your belief system might not always drive, and there is suspicion, of course, why wouldn't there be, of Western medicine when that's not really your cultural beliefs from before? It's very difficult. And I think embracing people where they're at, listening, being open-minded, and trying to say things like, it's okay for you to use whatever medicines you think will help. In addition, this might help you too, and there is some data that could show that it helps. Having their learning aids where they're actually translated in a way that is culturally making sense, different health literacy, different reading ability, and some taboos that I wouldn't have been aware of. She mentioned that if it's a pill bottle that's open and spilled as a pictograph, that actually drums up in the mind of some people narcotics, which has devastated some First Nation communities. So I thought all those things were good take-homes for me to try to apply into my practice.
Again, I think there was some highlighting of like there's cultural barriers and geographic barriers. So actually having people come to the community to offer care is really important. In BC, much of our specialty care is focused exclusively in the Lower Mainland, and it's a big province. So it is hard to deliver care in more remote areas. And certainly I've definitely been guilty of having this thinking that wouldn't it just be easier to just fly everyone to me? It would for me, but I think that there's a lot of importance to be placed on actually like some of these folks will be more comfortable having care delivered within their community. That's a really important area. But then that geographic barrier is added onto or exacerbates some of the cultural barriers.
And as Cheryl said, she even went to do COVID vaccines for a couple of months. And I remember that time. And we actually had a really good uptake in Indigenous populations with the vaccine. And she's one of the reasons that there was such a good uptake. Because I think if we would have told them that they had to go where all the other people had to go, I don't think it would have been such a good uptake of like the COVID vaccine.
Yeah, and I completely echo the advocacy that Dr. Barnaby has done over the years. Honestly, things that we take for granted. So I have been on staff in Edmonton for not very long, but long enough to see some of the changes that she was actually leading, which is, I have to say, is remarkable. And she also emphasized that it really does take a village. And she thanked lots of people, and she acknowledged that none of this work, this life's work of hers, was going to be possible without all of the various champions that she's had that have really worked with her along the years. So it was a really nice talk. I enjoyed it.
I think that was a really beautiful way to cap off an excellent meeting. And so now we get to, I think, head to the gala tonight and party, but also think about next year. So that I understand is going to be in Vancouver, my hometown. And Mo, you'll be the ASM chair. Is that correct?
That's what they tell me.
He's signed up for it unknowingly.
So we're going to say thank you to everyone for listening to these special episodes. So that's a wrap for day 3 of the annual scientific meeting here in Halifax. A special thanks goes out to our podcast team here in Halifax for the ASM, Dr. Dax Rumsey, Dr. Janet Pope, Dr. Marinka Twilt, Dr. Mo Osman, Aaron Stewart, and David McGuffin of Explore Productions. Our theme music was composed by Aaron Fontwell. For more information about the work of the Canadian Rheumatology Association, visit rheum.ca. And with Janet Pope, I'm Daniel Ennis, and thanks so much for listening.